So thank you everyone for joining and for spending your afternoon with me to learn a little bit about urogynecology. I'm excited to be here today for this Women's Wellness webinar series. I think it's an important topic that we're going to talk about, so I'm happy to have your participation. If there are any questions, we'll address those as well. So this is a little bit of information about me. My name is Nina Bhatia. I am a board-certified urogynecologist. So what that means is I did a 4-year residency in OBGYN, where I delivered babies and did general women's wellness and general gynecology. When I completed that 4-year residency training program, I did a 3-year fellowship in urogynecology, where I learned specifically about what I get to do every day, which is take care of women who are suffering with urinary incontinence and pelvic organ prolapse. So that was a 3-year fellowship. And when that training was done, I became board certified in both OBGYN and urogynecology, but I practice only urogynecology. I do both robotic and vaginal surgery and also a wide range of office-based treatments. I have 2 practice locations, so I work as part of Hackensack Meridian Health Medical Group. So we have an office location for urogynecology for my practice in Old Bridge, New Jersey, and also in Monroe Township, New Jersey. I do operate and do procedures out of several Hackensack Meridian Health hospitals, including Bayshore Medical Center, JFK University Medical Center, Old Bridge Medical Center, Riverview Medical Center, and Jersey Shore University Hospital. So for women in New Jersey who are suffering with any urogynecologic condition, there is a place that we can help you. There are locations where we can take care of you. And before we kind of get into the objectives of the talk, I just wanted to also just give you reasons why. Why do I do this? Women's healthcare is so important. There's so many things that we do in our lives, from getting pregnant, taking care of children, having children, taking care of families, and we do a lot to take care of others. But there are times where we have to take care of ourselves also. And so for me, I was always drawn to women's healthcare. I just think it's an important um, uh, field in medicine where women do so much for other people, but who's going to take care of us? And when I went into med school, I wasn't sure what I wanted to be or what type of doctor I wanted to be, but I was so drawn to women's healthcare. I just think it's such an important field. And it doesn't just stop with having children. There are other times in our lives where we need to take care of ourselves, and there's things that happen to our bodies over the years after having children that affect us. And that's part of why I chose to become a urogynecologist. I wanted to help women of all ages suffering from a multitude of different problems that are affecting their lives. And that's why I became a urogynecologist. So our objectives of the talk today are to talk about what is urogynecology. We'll go over some of the different conditions that are common in this field, some of the pelvic conditions that affect us, which include prolapse, overactive bladder, stress urinary incontinence. We'll talk about signs and symptoms that can affect you, that would prompt you to want to see a specialist like myself. And we'll go over some of the different treatment options, both surgical and non-surgical. And again, if there's any questions, we'll definitely have time to address those as well. So what is urogynecology? I kind of briefly mentioned a little bit of my background of how I got here, but women's healthcare and specifically urogynecology is a subspecialty where we take care of women only. So to become a urogynecologist, you can either start off as an OBGYN or as a urologist, but you have to do that basic training first in either of those 2 fields. So we know for OBGYN, that is a field where you are caring for women only, whereas urology is a field where you can take care of both men and women. So you can start out in either one of those areas and then focus your training on urogynecology specifically. And in this field, we take care of women only who are suffering with conditions like pelvic organ prolapse or incontinence. So there's further training that you'll do outside of either OBGYN or urology, which typically is something called a fellowship, which can range from anywhere from 1 to 3 years to further learn about this specific field. So the training is very long. It's usually approximately 7 years that you'll spend as a physician learning how to specialize in this field. Some other terms that you may have heard of for this field are female pelvic medicine and reconstructive surgery, urogynecology or even female urology. This is a board certified specialty. So if you are looking for a urogynecologist, that's something to take into consideration, that you might be looking for a board certified urogynecologist who's done fellowship training in this specialty to really take care of you. So, one of the areas we want to talk about is the pelvic floor. What is the pelvic floor? So, you may hear that term and not really know what that is. The pelvic floor is a combination of the organs that are supporting us, which include the uterus, the bladder, the rectum, and the vagina. And there's a whole host of muscles, ligaments, and connective tissue that help hold those organs in place. And unfortunately, over time, those ligaments and those muscles weaken. And when they do, we can start to run into problems with our bladder control, stool control, or something called prolapse when those organs actually fall or drop. So, support of the pelvic floor is important because those muscles, ligaments, and connective tissues over time weaken. And I'm sure many of you have heard of the Kegel exercises, and we'll talk about that a little bit today. But the pelvic floor just refers to these muscles, these ligaments, the tissue that connects all of these areas that are supporting these important organs of the bladder, the uterus, the rectum, and the vagina. As a woman, your chance of getting a pelvic floor disorder is actually quite common. And I usually put this slide up just to kind of get my audience thinking about, well, what are my odds of having one of these conditions? And it's probably more than many of you may think. It's 1 in 3. So 1 in 3 women are suffering with some sort of problem of the pelvic floor, whether it's a prolapse and the organs are coming down, or they're suffering with trouble controlling their urine, not getting to the bathroom in time, maybe losing urine if they exercise or cough or sneeze. And for many women, they're having trouble with their stool control. Some of the other issues that you can develop when you have a trouble with your pelvic floor is urinary tract infections as well. Sometimes pelvic pain, pain in the bladder. So the likelihood or the possibility of you having a condition that's affecting your pelvic floor is 1 out of 3. So it's pretty common. The common pelvic floor disorders, and again, there are many, but the most common are urinary incontinence, which is loss of urine or having accidents with your urine control, pelvic organ prolapse, when the organs start to fall, urinary urgency and frequency. So that's running to the bathroom often. When you have to go, you have to go. It's urgent. You have to stop what you're doing and go to the bathroom. You may not make it in time. Nocturia is getting up at night. So if you're sleeping through the night and you don't have to wake up to go to the bathroom, that's wonderful. But there are many women who either go to the bathroom multiple times before they finally are able to fall asleep, or once they actually fall asleep, they're woken up by the need to go to the bathroom. And some women can make it and some cannot. Some women are having accidents or needing to wear pads because they can't control their urine at night. And they may get up multiple times during the night, and that can obviously be very disruptive to your daytime. If you're not getting enough sleep at night because you're constantly getting up to go to the bathroom, that can affect your daytime as well. And that's called nocturia. So these are the most common things that I treat. Whether it's trouble controlling your urine, trouble getting to the bathroom, waking up at night because you have to urinate, or if you have prolapse where the organs actually fall down. And the bulk of the patients that I see are coming in for these conditions. And just to kind of go back, these conditions are what I spend my days doing, treating women that are having these problems. And it truly allows me to be a specialist in this field because although I've done a lot of training to get here, I really focus on these conditions. So if you're having these problems, it's really important to see a specialist who specializes in these conditions because there's so many treatment options and we can get you so much better. We just need you to come in and start the process of at least seeing us so that we can help you. So, what is urinary incontinence? It's any loss of urine that's unwanted. So, meaning it could be a few drops of urine leakage. Maybe you can get to the bathroom most of the time. Maybe as you're putting your key in your front door or opening your garage door or pulling up to your house, all of a sudden that urge hits you and you have to go to the bathroom. And as you're getting out of the car or getting through your front door, you're kind of doing that little dance and trying to run to the bathroom, and maybe a few drops are starting to leak out. That's actually incontinence because you don't want it to come out, but it's coming out when you don't expect it to or when you don't want it to. For some women, it's more than that. Their entire bladder lets out, or it's a large volume of leakage. So any loss of urine, whether it's a few little drips to your whole bladder letting itself out, any loss of urine that's unwanted is incontinence. And for some women, it's not in that urge setting. It might be more of when they cough or sneeze. So any loss of urine, any leaking of urine that you're having is incontinence. It may be every day, it may be only a few times a month, but if it's happening at all, it's considered incontinence. So some of the most common symptoms I just sort of mentioned, where it could be you're getting to your front door or getting home. It could be simple things like you're out with friends and you're laughing, or you're sick and you're coughing. If you're exercising, lifting, running, jumping, doing any kind of physical activity, you may not be able to hold the urine in because the muscles aren't strong enough. It could be a frequency issue where you're running to the bathroom all the time. Normally, you should be going to the bathroom maybe every 3 to 4 hours. So if you're going more often than that, let's say every hour, every half hour, every 2 hours, any amount of time that you're going to the bathroom, which is more soon or more frequent than every 3 to 4 hours, is considered frequency. And urgency is that feeling that you have to go. So we all know that feeling that you get when you're like, oh, let me stop what I'm doing and go to the bathroom. For some women, they get it all the time. They feel like they have to go constantly throughout the day or constantly throughout the night. So an urgency is that strong feeling that you have to go to the bathroom and you really can't defer it. You have to stop what you're doing and you have to go to the bathroom. Nighttime, sleeping through the night, waking up wet, waking up because the bed is wet, or waking up because you're feeling the urine starting to come out. For some women, they're having trouble emptying their bladder. When they go to the bathroom, they sit on the toilet and only a little bit comes out, or a lot comes out, but then they feel like they still have to go, so they sit there and wait for a longer period of time to get more and more urine out. These are all symptoms of urinary incontinence. For some women, they lose urine with intercourse, with sexual function. They may be sexually active and losing urine with intercourse. So there's lots of different times that you can lose incontinence. You can lose urine and have incontinence. There's different situations. The most common are things like coughing, sneezing, laughing, running, jumping, exercise, or with urge, when you feel that urge to go and you just can't make it, can't hold it. If you suffer from incontinence, you're not alone. So we had talked previously about the risk of having any kind of pelvic floor disorders, 1 out of 3. The risk of having any kind of urinary incontinence is 1 out of 4. So 1 out of 4 women are suffering with some form of incontinence. Again, whether it's little drips of urine once in a while or your bladder's completely letting itself out all the time. It's a 1 in 4 chance, which is pretty common. So between you and 3 of your friends, at least one of you is probably having some trouble with urinary control. And that's something that we want help with, that we could make better. Unfortunately, urinary incontinence tends to increase with age. So as we get older, the risk of losing urine continues to get worse. It gets worse every year that goes by. So if you're already having some trouble with your urinary loss, chances are it's not going to go away on its own, and that you need some kind of help to get it better. And waiting doesn't help. So if you're having trouble with getting to the bathroom in time, you're not making it, maybe it's only happening a few times a week or a few times a month, but it is happening. The sooner you do something about it, the better off you're going to be. If you wait, we know, and the studies tell us, that it gets worse every year with age. So as you continue to get older, it gets worse. So maybe you're wearing a thin panty liner now, but in a few years, you might need to wear a very thick pad because it's happening more often. So, so one of the things I like to tell patients is don't wait. If it's happening, if it's bothering you even just a little bit, at least come in and let's talk about it. Let's hear what your symptoms are. Let's go over the treatment options and see if there's a treatment that we can provide for you that's going to help you get better. Because we know if you leave it alone, it's only going to get worse. And it doesn't help to wait a few years or just wait and see if it gets better, because it's probably not. It's going to probably get worse as you get older. And again, we talked about the fact that it's so common and you're not alone. And that's the hard part with incontinence. We don't like to talk about it. Women don't really mention this sometimes to their primary care doctors or their GYNs or any other doctors. There are times that you may mention it to your doctor and you might be told to do Kegel exercises. And while Kegel exercises can help you to some degree, there's so many other treatment options available for you to get you so much better. So again, if it's a problem that you're dealing with, whether it's a minor problem or a major problem, if it's a problem at all, it's important to come in and get help so we can figure out the best treatment option for you, so we can get you better without it getting worse over time. And you're not alone. Every patient I see is coming in for the most part with some form of incontinence. There's so many women that are dealing with this condition that, it's very treatable. So we're here to help, whether it's me or any other urogynecologist. It's important to get yourself treated and to get some help for this. What can cause incontinence? Is it just age? I mean, age is part of it. We know it gets worse as we get older, but what else? Any kind of weakness in the pelvic floor muscles can cause this. So, there's lots of different reasons why you can have weakness in the pelvic floor. It could be age related, but it can also be from childbirth. Um, Urinary tract infections can lead to incontinence. Certain things that we drink can cause incontinence. So, things like caffeinated beverages, such as coffee, tea, or any of those energy type of drinks, anything with a lot of caffeine can really affect your urinary control. Alcohol can affect your urinary control. There's medications that a lot of women take, diuretic medications or water pills that help you eliminate fluid from your body, but that also can lead to a little bit of incontinence. So there's so many different reasons. Constipation is a big one. So it may not seem like it makes sense as to why, but the pelvic floor is such an area of the body where all the organs are so close to each other. So the rectum, the vagina, the uterus, the bladder, they're all right there next to each other. And if you're having constipation, that can actually affect your bladder control as well. There are some women who have other issues like MS, Parkinson's, or other neuromuscular disorders that can affect urinary control. And then there's other issues such as kidney stones, pelvic organ prolapse, where the organs are falling, that can also affect your urinary control. So there's a lot of different reasons why you may be having trouble with urinary incontinence. And again, age is a big part of it. While we know the incontinence gets worse as we get older, there are many women in their 20s, 30s, even teenagers that have trouble with urinary control. So it can really affect women of all ages at different points in their lives. And although we know that it may get worse with age, it can start at a very young age. I often get patients come in to see me that say, "Oh, I'm too young for this." But the reality is you're not. It can start at a very young age. Unfortunately, there's children and even teenagers that suffer with urinary incontinence. So it's important to identify it, that if you're having trouble with your urinary control, you're not too young for it. It can happen at any age, and we know it's going to keep getting worse. So let's fix it. How do we diagnose incontinence? This can be diagnosed by anybody. You don't have to have it diagnosed by a specialist like myself. It can be something that you discuss with your primary care or your GYN, or it could be with a urologist or a urogynecologist. But the key is if you're identifying that you're having any trouble holding your urine, if you're running to the bathroom all the time, it's good to bring it up with your doctors, whether it's your primary or your GYN, or you can come and see a specialist like myself or a urologist. When you do come in to see us, we will get some information and ask you about your symptoms and your medical history. We'll do a physical exam to see if there's any anatomical reason as to why this is happening. A physical exam could include a pelvic exam, which is similar to what you would get when you would go to a gynecologist, but we're not doing pap smears and we're not doing general gynecology. When you're coming to see us for urinary incontinence, we're really looking for your pelvic floor support and to see if anything is falling or dropping or coming down that can be affecting your urinary control. We also check to make sure, are you emptying your bladder? So commonly I'll hear patients tell me, well, I go to the bathroom all the time, but it must be because I'm not emptying. The truth is that most women are emptying their bladder, but they just feel like they're not because they feel like they have to go to the bathroom all the time. So that's one of the very first things we'll check when you come in as a new patient. We have you urinate, give us a urine sample, make sure there's no urinary tract infection. But we also do something called a bladder scan, which is a very simple way of checking to make sure your bladder is actually emptying. And we have that information right away when you come in, and that's really helpful because when we want to make sure your bladder is able to work properly and that it's able to empty, and then we try to figure out, well, why is it not holding your urine, and we'll work with you to figure out what the problem is and why you're having the incontinence, so then we can then figure out what the best treatment option is. So, if you are having trouble holding your urine, that's a good time to see a specialist. If Are you wearing a pad? So maybe you've learned how to deal with it. Maybe wearing a panty liner or a pad is helping control the urine not get onto your clothing or allowing you to leave the house where you're not having accidents that are affecting your daily life. But wearing a pad is not necessarily always the best thing because it can affect your skin. There's some increase in UTIs with wearing a pad. So if you're wearing a pad already, that's a sign that you probably should at least see somebody to talk about the symptoms and to see what your options are to help with that. If the urge to urinate is affecting your day-to-day life, so whether you're taking lots of bathroom breaks at work or you're sort of planning your day around the bathroom, and that would be mapping out where the bathrooms are. So let's say you have to go to the grocery store or you're commuting to work, but You go to the bathroom before you leave the house. You go to the bathroom as soon as you get there. You kind of know where all the good bathrooms are. If that's how your daily life is, that's a good time to see a specialist. So you can talk about those symptoms. Why are you doing those things? And how can we help you where the bathroom isn't really something that's kind of taking over your life? Um, do you restrict your fluids? So restricting your fluids is something that patients often do because they feel like, well, if I don't drink as much fluid, I'm not going to have as much urine and I won't have as many accidents. Um, and that may help temporarily, but it's not a really good treatment option. But it is something that patients often do. Restricting your fluids isn't great because you can cause yourself to have dehydration. And it's just not good for your body to restrict your fluids unnecessarily. So if you're finding that you're just not drinking as much water, cutting down on your fluid intake because of trouble with bathroom control or going frequently or having trouble with urine control, that's a good time to see somebody for this. Um, is incontinence affecting your intimacy or your sex life with your partner? If it is, come see us because there's some easy fixes for this. And what I hate to see the most is when women tell me they stopped going out. They stopped going out with their friends. They stopped exercising. They don't go to social events because they're afraid of having an accident, or they really don't want to have to wear pads, or they're carrying around extra clothes. And if these are the things that you're having to do, or if incontinence is preventing you from doing what you want to do, it's a really good time to come see a specialist so we can help you because there's so many easy fixes for this condition and we can often cure it. So if any of these things are happening in your day-to-day life, uh, I would encourage you to come see a specialist so that you can talk about your symptoms and find out what the treatment options are. Um, I often have patients come in who are getting ready for their son or daughter's wedding, and they have this beautiful gown that they have to wear, but they have to wear a pad with it, or they're afraid of dancing in front of all of their friends and family and having an accident. So don't wait until there's some big event or something coming up. If it's just affecting your everyday life, that's good enough for you to come in and to get some help for it. So we're here to help you. The types of incontinence, there's lots of different types, but the most common are stress incontinence and overactive bladder or urge incontinence. So stress incontinence is leaking with activity. It could be cough, sneeze, laugh. It could be running, jumping, bending, lifting, any kind of physical activity. And that's from more of a weakness of the muscles and ligaments in that area. And there's some easy fixes for that. Overactive bladder or urge incontinence is also quite common. And again, that's the waking up at night or nocturia, frequency where you're going to the bathroom very often, or urgency where that strong urge hits you and you really have to stop what you're doing and go to the bathroom. Some women have overactive bladder without incontinence. They just have the urge to go. They go very frequently. They wake up at night, but they're able to make it. And while that's not maybe particularly as bothersome as having the leakage, it's still an issue for lots of women. So if you're going to the bathroom frequently, running to the bathroom all the time, waking up at night, even if you're not having accidents, even if you're not having leaking, that's actually something that can be fixed as well. And some of the other types of incontinence are called mixed incontinence, where you may have both. So it's very common for women to have both issues. They may leak with coughing and sneezing, but they may also have trouble where they get the urge to go and they can't make it. So mixed incontinence is when you have both. For some women, there's other issues. They're just losing urine and they don't really know why, but they're wearing pads, there's moisture, there's wetness, and they're not sure why that's happening. And that's something that we can treat. Sometimes there's other issues going on. Maybe there's trouble with dementia or being forgetful or not remembering to go to the bathroom, or there's medications that you're taking that are causing you to have urine leakage. So there's lots of different reasons why you may have leakage. The most common are the stress incontinence, which is, again, the coughing, sneezing, laughing, and physical activity, or the urge incontinence, where you get the urge to go, but you just can't make it, or mixed, where it's both. How do we treat this? So there are non-surgical options. There are exercises you can do. There's physical therapy. There's Kegel exercises. There's some simple ways that you can do some bladder training where we look at how often do you go to the bathroom. We may have you write down on a piece of paper or a little diary. Are you going every hour, 2 hours, 3 hours? We kind of gauge how often you're going, and we try to increase that a little bit at a time. So we do some bladder retraining. Um, the other options include medicines. So there's plenty of different medicines out there. Some work really well, some don't. We have to look to see what medications you might be taking and to see what the best option is for you, but there are medication options as well. There's some office-based procedures where you come to the office, we do simple procedures, and you go home the same day, and you're back to normal the next day. There's some surgical options where you may have to have some light sedation, similar to like a colonoscopy, and you come in and we do minor surgical procedures where you are back to normal the next day and can continue living your daily life without any interruption and have your urinary incontinence fixed with a simple procedure. Sometimes there's a combination where we might do a medicine and a procedure. So there are plenty of options for you, and most of them are really non invasive and can be done very quickly and get you back to normal pretty quickly. The non-surgical treatments we kind of touched on a little bit, but the bladder training, we look at your diet, we look at where you're drinking every day. So when you come in to see me, it's helpful if I know, do you drink coffee? How much coffee do you drink? How much water do you drink? I like to look at what you're drinking because sometimes we can make changes. Remember, caffeine, alcohol, um, juices, carbonated beverages. There's so many different things that can affect your bladder control. So it's important to know what is it that you're drinking or eating on a daily basis that could be affecting your bladder control. The bladder training, as far as the timing, there's physical therapy, there's biofeedback, there's even supportive devices that we can place in the vaginal area that can help support the urethra and bladder to help with urinary control. So there's some simple fixes that don't require surgery or don't require medicines that you may be a candidate for. If you do require medicines to help this, the goal of the medicine is to help with the overactive bladder or urge incontinence. It will help decrease the amount of time that you're going to the bathroom, so the frequency. It will cut down the urge, so you're having less of that strong urge to get to the bathroom. And for women with the nocturia, where they're getting up at night, the medicines can help decrease the number of times that you're going to the bathroom and give you better control where you're hopefully actually making it to the bathroom. Some of the medications work directly on the muscles of the bladder to stop any unwanted bladder spasms or bladder contractions that are causing excessive frequency, urgency, or urinary loss. Um, there are some medications that are newer that work a little bit better and more specifically in those bladder muscles. So medications have been around for urinary control for a very long time. And a lot of the older medications had side effects, dry mouth, dry eye, constipation. And many of you may have tried those medicines or maybe don't want to try the medicines because you have a friend that tried them or you've heard about those side effects. The good news is there's newer medications. And the newer medications work very differently than the older group of medicines. And they're more specific to helping the bladder control without those unwanted side effects. So there are definitely medication options out there for patients. For office-based procedures, some of the things we do are bladder Botox, urethral bulking, and then there's a procedure in the office we do called PTNS. So bladder Botox is something that is injected into the bladder. It takes just a few minutes to do. You can be wide awake for it. You don't need to be sedated, although there are some patients that prefer to be sedated, and that's an option as well. But for those of you who choose to do this in the office, it's a simple office-based procedure. And what the Botox does, it helps stop those unwanted bladder spasms or contractions in the bladder, which helps give you better control when you have the urge to go so you can actually make it to the bathroom in time. Is really life-changing for many women, and it lasts for, on average, 6 to 9 months. So it does need to be repeated. So typically about twice a year, patients come in for a very simple, quick office-based procedure where we're changing their lives and helping them control their bladders. It works very well, very low risk. I've been doing Botox in the bladder for more than a decade and with very good results. Patients have been very happy with it. We'll skip down to the bottom of the slide where it says PTNS. That's another treatment option that we can do in the office for overactive bladder or urge incontinence or nocturia. PTNS is short for peripheral tibial nerve stimulation. It's very similar to acupuncture. It's a very tiny acupuncture type of needle that goes on the ankle. It helps control some of the nerves of the bladder to improve the signals. So your bladder is getting less of that unwanted signal to go to the bathroom and more of the signal to go when you really do have to go. So you can cut down the urge to go, the frequency, the nocturia, the urge incontinence by a simple office-based procedure. It's relatively painless. It's very similar to acupuncture. Patients usually enjoy it. It's about a half hour in the office once a week for a few weeks to help constantly work on the nerves of the bladder to improve the signals. And then the third office-based procedure that we often do is something called urethral bulking. Urethral bulking is for women who have stress incontinence, who may be leaking urine when they cough, sneeze, laugh, run, and jump. Urethral bulking is an amazing procedure. It's really life-changing. One of the procedures that I offer for urethral bulking is called Bulkamid. And Bulkamid is a water-based gel that's injected into the urethra, and it's to help kind of make the urethra a little bit more narrow to block it off so that if you were to cough, sneeze, laugh, run, or jump, you won't leak urine. It's very successful. It's 85 to 90% improvement for most women, and it lasts many years. In the past, there was urethral bulking that we would offer patients that maybe only lasted a few months. Bulkamid has really improved that. And in studies, we're finding 7 years later about 85% improvement still. So it's a longer term therapy to help with stress incontinence, which is leaking with coughing, sneezing, and laughing. It can be done again in the office, or it can be done under sedation if preferred. There are surgical options that we offer for patients too. There are slings that we use to help support the urethra. The sling is something that's more of a longer term fix, whereas urethral bulking is something that is a short procedure that can last many years. Slings are also a short procedure, but slings are done under sedation, and they're intended to last potentially lifelong. We have data that shows us that it lasts for many years, beyond a decade, if not longer. So slings are more of a longer term therapy for leaking with coughing and sneezing. There's other procedures that we also do for surgery. Sacral neuromodulation is one. Sacral neuromodulation is a small outpatient procedure that we can use to help work on the nerves of the bladder. And this is a great long-term therapy too, and studies are showing us that this therapy can last 20 years, if not longer. So the surgical treatments that we can offer you for urinary control are minimally invasive, typically short procedures, less than a half an hour, often done under just light sedation that you would get for a colonoscopy, and are lasting for many, many, many years. So the incontinence can really be fixed and can often be cured with a lot of these procedures. If you do suffer from prolapse, which we'll talk about a little bit, prolapse is when the pelvic organs are dropping, which could be your bladder dropping, the uterus, the rectum, the vagina. If you have a prolapse where something's falling or dropping, there's surgeries to correct that as well. Women are suffering for years with these conditions. So we know that many women are suffering with urinary incontinence. We know that 1 in 3 women will have some sort of pelvic floor disorder, and that 1 in 4 women will have some sort of incontinence. We know that it can start at any age, and we know that it gets worse with time. But what are we doing about it? So unfortunately, we spend a lot of time having children, raising children, taking care of our families, but we don't often take care of ourselves. And that's something that I think it's so important that we stop and take a moment to take care of ourselves. In order for us to help other people, we have to sometimes make sure that we're taking care of ourselves and making sure that we're healthy so that we can help our family members. Women who have incontinence wait a long time before they even talk about it. Most women are waiting anywhere from 1 to 5 years, or even more than 5 years, before they even mention it. So most of the time, when I see patients, they'll tell me that they've had their symptoms for 2, 3, 5 years, 10 years, 20 years, a long time. If you're having urinary incontinence, you don't need to wait. It is treatable. It's often curable. There are so many specialists and doctors out here who can help you with this. And to see a urogynecologist like myself, you often can just call and make an appointment. Most of the time, you don't need any kind of referral. If you do need an insurance-based referral, that's something we would, help you with to get. You don't have to see your primary OB/GYN first before seeing a specialist for something like this. If you're already seeing a primary or a GYN and haven't mentioned it to them, you can mention it to them also and see if they can get you started on treatments. But if you're suffering with incontinence, it's really important. Don't wait. There's so many fixes out there. There's office-based procedures, there's medications, there's lifestyle changes, dietary changes. There's something for everybody, and there's a way that we can fix the incontinence. It's not something you have to suffer with, and you don't have to hold on to it or not talk about it. We're here to help you. This is a website for patients. It's called voicesforpfd.org. It's from the American Urogynecologic Society. So it's one of our medical societies. And it's like a life impact tracker. So you can kind of, if you're not really sure, well, how much is this affecting me? I've had this for a really long time. I can deal with it. It's not that big of a deal. Something like this can be helpful because you can sort of fill it out and see maybe it is affecting you more than you think. Maybe you haven't had the chance to stop and to think about how it's really affecting you. So I would encourage you to go on this website as well, voicesforpfd.org. There's a lot of useful information. There are these leaflets that they have for patients which talk about pelvic organ prolapse, urinary incontinence. We didn't talk much about pelvic organ prolapse today, so I'm going to briefly kind of mention a little bit about this as well. Pelvic organ prolapse is when the pelvic organs fall or drop. And again, this is something that happens age related. It can be related to having children. It's genetic. It can be from lifting. Women have chronic constipation. There's so many different reasons why your pelvic floor muscles will um, weaken over time, and you may develop pelvic organ prolapse. And again, there's a 1 in 3 chance that you may develop one of these pelvic floor conditions. So it's quite common. If you go on that website, voicesforpfd.org, you'll find this exact leaflet on there. And this is something I like to give to patients so that they can read a little bit more about prolapse. And it just shows you some pictures of what normal anatomy is. Where's the bladder, the rectum, the uterus? Where are these organs supposed to be? And what does it look like when they fall? A cystocele is when the bladder is dropping. A rectocele is when the rectum is dropping. Uterine prolapse is when the uterus is falling. And then vaginal vault prolapse is someone who may have had a hysterectomy. Maybe they've had their uterus removed, but they can still have the vaginal walls coming down, which can affect the bladder and the rectum. So prolapse is when those organs start to fall. And patients often feel something like a bulge. They feel something bulging out. Some patients refer to it as like sitting on an egg or something falling. So if you do feel like something's falling, dropping, or coming out of the vaginal area, that's something that you can start with your primary or your GYN, or you can come and see us and let us know, and we'll take a look and let you know what's happening, and then we could talk about the different treatment options. For pelvic organ prolapse, the treatment options are non-surgical. There are pessaries, which are devices that can be placed in the vagina to support. There are surgeries that can help. There is physical therapy. So there's non-surgical and there's surgical options for prolapse. And that's something that we can help you with as well. These are just some really helpful resources if you wanted to go online to learn a little bit more about urinary incontinence or pelvic organ prolapse. AUGS.org or voicesforpfd.org, or where you can find those leaflets similar to the one I just showed you about prolapse, but they do have plenty of leaflets on urinary incontinence and other treatment options. They have information about UTIs as well. Yourpelvicfloor.org is from the International Urogynecologic Association, and they have leaflets in multiple different languages as well. So there's some really good information at all of these websites. I had recently done an on-demand webinar, and this is the website for that, femalepelvicsolutions.com. And you can get some information there as well about everything we talked about today, and sometimes even in more in-depth information, because unfortunately this is a short webinar, so we can't talk about everything. But I tried to at least give you a brief overview of the conditions that I can help you with, or that a urogynecologist can help you with. And lastly, we'll leave with this slide. If there are any questions, I think we're putting those in the chat to address. This is my office information. So this is my phone number for both locations. Again, I have an office location in Old Bridge and Monroe, and these are the hospitals that I take care of my patients. So if you're anywhere in New Jersey, there is a urogynecologist that can help you. I am in practice in these locations, but there are plenty of us within the medical group that can help you throughout New Jersey. So with that, I'll leave it for any questions. Kaylin, I guess just let me know if there's any questions that I can address.
Sure, we have a couple that are here. The first question is, I had incontinence and was given Detrol LA. However, the examination I endured was very painful, even though the physician put some sort of gel on the apparatus that was used. She said it was for the pain, but it did not help. Has there been any update to ensure a painless examination?
So GYN exams are definitely something that can sometimes be painful for some patients. And it really depends, I think, on the situation that the patient's dealing with and also the provider that they're seeing. So if you have had trouble with a GYN exam in the past or a pelvic exam in the past, I would definitely bring that up to the provider before you get examined so that they know what your past experience has been and that they can make sure they're doing everything that they can to help guide you through the exam to make it less uncomfortable. But there's different ways that the exams are done, and there's different things that we're looking for when we're doing exams. So it's hard to address that completely. But I would just say that if you have had trouble before, or if you're just concerned and maybe you've never had trouble with an exam before, but you're a little apprehensive about it, or you're worried that there might be some pain, I would absolutely say that it's a good idea to bring that up with your provider before you go into the exam room. So that way you can address those concerns.
Thank
And
you.
Tetrol LA is one of the older medications that are used for overactive bladder or urinary incontinence. And unfortunately, there's lots of side effects with that medication. There are other better, newer medications to help with overactive bladder. Tetrol LA, though, is not typically used for pain. So that might be something you might want to address with the provider that you're seeing.
Very appropriately, the next question was, what are some of the newer medications?
That's a great question. Okay, so some of the newer medications are they're called beta agonists, and there are two: Myrbetriq, which is recently became a generic medication, and Gemtesa. Myrbetriq and Gemtesa are beta agonist medications that work in a different way on the bladder compared to the way the older anticholinergic medications worked. They're a little bit more specific in the bladder, so you're more likely to get improvement with those medications with fewer side effects because they work on a different receptor in a different way than the older overactive bladder anticholinergic meds work. So, for example, Getrol LA being one of those older anticholinergic medications, the common side effects with those are dry mouth, dry eye, constipation, acid reflux. There's even some studies that are showing some associations with dementia with long-term use of those anticholinergic medications. Whereas Myrbetriq and Gemtesa, because they are beta agonists and they're different from those anticholinergics, we don't tend to see those types of side effects, and we see much better improvement. Although they're new medications, they're not that new. Myrbetriq has been around for more than a decade. Gentessa has been out, I want to say, about 4 or 5 years. So while they're the newer medications, the good news is that they've been out for a long time. There's a good amount of data and studies on those medications. So they're not any experimental type of medicine. We've got good data and good information on these newer medications.
Thank you. The next question is, are the surgical treatments covered by insurance?
So that's a really good question. And the surgical treatments that we offer for incontinence and prolapse are considered medically necessary. They're not cosmetic procedures, where sometimes cosmetic procedures may not be covered by some insurances. These are medically necessary conditions and medically necessary procedures for most patients. So obviously, it depends on your insurance and the specifics of your plan, but they are usually not it's usually not a problem as far as insurance coverage for these types of procedures.
Okay. The next question is, can you explain how to properly do Kegel exercises?
Yeah, that's a great question. And Kegel exercises are so important. So we want to preserve and protect our pelvic floor, and we know that the muscles and ligaments weaken over time. And they weaken just with age. Having children can exacerbate that weakness, but in general, we know that the muscles weaken. So if we want to do Kegel exercises, um, while we can verbally talk about it, it is something it's so much better when you're able to examine a patient and allow them to do a Kegel so that you can check to see if they're doing it properly. And if they're not doing it properly, you can sort of guide them both verbally and physically as they're practicing trying to do the Kegel. Physical therapy is very helpful for that as well too. Pelvic floor physical therapy is so valuable for improving those pelvic floor muscles. But to do a Kegel exercise, sometimes we explain it as um, if you were wearing a tampon, for instance, or if you felt a tampon was falling out, you would want to squeeze almost as if you're trying to pull it back in. Um, some other ways to think about it is you're squeezing almost the same squeeze you might do if you're trying to hold your urine or if you're trying to keep the urine inside as you're running to the bathroom. But it's sort of a pulling in. And there's so many muscles in the pelvic floor. And when you're doing a Kegel exercise, you want to isolate those specific muscles and not use, for instance, your gluteal or buttock muscles or your abdominal muscles. You really want to focus only on the pelvic floor muscles. And that's sometimes very difficult to do, which is why it's very helpful to either see a specialist like myself or even your gynecologist or a pelvic floor physical therapist to really help work on those pelvic floor muscles so that you're making sure you're doing the Kegel properly. If you're not doing Kegels properly, sometimes you can cause unwanted muscle spasms, which can lead to pain. So it's important that you're doing it properly. And a regular gynecologist can check on that when you're going for your GYN exam, or if you're already seeing a urologist or a urogynecologist, you can always ask us to help you with that. And then again, pelvic floor physical therapy is pretty helpful for that as well. Any other questions?
Thank you. The next question is there anything a woman can do now to prevent incontinence in the future?
That's a great question. So prevention is really important, and I think that doing those Kegel exercises and doing them properly is a great way. Paying attention to what you drink. So keeping hydrated with water is important. We want to limit our caffeine intake. So if you're drinking several cups of coffee a day, that may not necessarily be a great thing. Limiting our caffeine to, I would say less than 16 ounces a day does make a difference for most people. But again, it's going to be very dependent on the individual and their other healthcare needs. So it's hard to kind of give a blanket statement as far as what you can do to prevent. However, we know that exercising those pelvic floor muscles, properly hydrating, and avoiding too much caffeine can make a difference.
The next question is are there medications that you can take when you are prescribed Lasix?
Yeah, so that's a great question. So Lasix is a diuretic, or some people refer to it as a water pill. And unfortunately, some women do need to take Lasix because they need it for certain heart conditions or other conditions where they may need to get rid of some excess fluid in their bodies. And with those medications, you may be producing larger volumes of urine. And if you're already having something like overactive bladder, where you're going to the bathroom frequently or urgently or having accidents, um, that excess fluid can sometimes exacerbate your overactive bladder symptoms. All of the overactive bladder treatments that we offer can be used alongside with taking the Lasix. So we never want you to stop taking the medication that's being prescribed to you by another physician. We want to help work with your overactive bladder to get that better. So all of the overactive bladder treatments that we talked about today, including all of those medications, um, can be used alongside with something like Lasix. But again, you'd have to come in so we can see what your specific needs are and go over your medical history and make sure we're choosing the right treatment option for you.
So I have two questions that are similar. I'm going to combine them.
Okay.
What is pelvic floor collapse and what is vaginal wall prolapse? And one of the questions they said they were hysterectomied.
I'm sorry, what was the second question?
What is pelvic floor collapse and what is vaginal wall prolapse? And the person was hysterectomied.
Okay. So pelvic organ prolapse, vaginal wall prolapse, pelvic floor prolapse, it's all the same. It's when prolapse is when the vaginal walls are coming down, which can include the bladder, the rectum, or the uterus. So any of those areas can be involved in a prolapse. Um, and there are treatment options for all of those different conditions. Whether you've had a hysterectomy, which is taking out the uterus, or not, there is a treatment option available for you, whether it's surgery or not surgical. But a prolapse of the vagina or the pelvic floor is when the vaginal walls, the uterus, the bladder, or the rectum are coming down. And the technical terms would be cystocele, rectocele, uterine prolapse, or vaginal prolapse. And that website that I had mentioned, voicesforpfd.org, actually has that exact patient leaflet that I had put up with all of those names of those different conditions, and briefly discusses all of the different treatments for prolapse.
And the last question is how often should we be doing Kegel exercises?
That's a really good question too, and I get that all of the time. It's going to be dependent on you individually. It's hard to give an exact amount to because every single person is going to be different. But the key with the Kegels is like any exercise, um, routine and doing it regularly. So if you're already, let's say, exercising a few times a week, Whatever your regimen is, you want to have a regimen with the Kegels as well, where you're doing it routinely. It's not something that you do once in a while when you remember. It's something that you're doing either daily or a few times a week. Daily is typically what's recommended, but again, it's going to depend on the individual. We have to make sure you're doing them properly and that you're not going to cause pain by overdoing them. We have to kind of check what your pelvic floor tone is to begin with. So while you can just start doing Kegels on your own, as far as specifically for each individual, it's going to vary, and there's going to be a recommendation that's going to come from whichever provider you're seeing for these conditions. But in general, Kegels are something that should be done regularly. If you just do them once in a while, they don't really help as much as if you were to do them on a regular basis, just like you would any other exercise routine.
There's another question. Can obesity cause pelvic prolapse?
Obesity is definitely linked to pelvic organ prolapse as well. Yes.
All right. So those are all the questions that I see in the chat. And if you do have any questions for Dr. Bhatia, as she mentioned, that's her phone number. Those are her office locations. Or if you want to scan the QR code, that takes you directly to her online Find a Doc profile. I want to thank you, Dr. Bhatia. This was wonderful. I got a few comments in here saying thank you. This was very informative, very helpful. So thank you for your time, and thank you to everyone who attended. We hope this was helpful for you, and we look forward to working with you in the future.
Thank you so much, everybody, for joining today, and I hope it was valuable for you. And thank you, Caitlin.